Hello and welcome to day 4 of Migraine Headache Awareness Week. Thanks so much everyone for being here tonight. Tonight's session is on living well with migraine with Dr. Bronwyn Jenkins. So for those of you who are new or attending for the first time tonight, the Migraine Headache Australia is a division of the Brain Foundation, and our mission is threefold. First is to provide information for people living with migraine headache disorders. So that includes resources like this webinar and a lot of the articles and other resources on our website. We also fund research. We are committed to we aim to fund one research grant into migraine or headache disorders through the Brain Foundation research grant program every year. And we also advocate and support people living with migraine and headache diseases. So that can be through government advocacy or our peer support group on Facebook and everything in between. Now, every day this week, we're highlighting some of our work throughout the past year, and tonight we're focusing on our recent research conducted earlier this year in partnership with Jean Hales for Women's Health. So there was a survey which over 1,200 people responded to, which was amazing to see. And we had conducted 3 focus groups which explored all different aspects of migraine. So asking everything from experiences with doctors and diagnosis to everyday impacts and experiences with treatment and management. And then Jean Hales also incorporated a migraine screening questionnaire into their National Women's Health Survey, which they conduct every year. And this really helped us to get an understanding of the real prevalence of migraine in Australian women. And as you can see in that first headline finding, this was a lot higher than previous estimates. So the research showed that 30% of Australian women experience migraine when it was previously thought to just be 20%. The other key findings were that only a third of women have sought help for their migraine or headache. And also that most people said that migraine affected almost all areas of their life. So work, health, relationships, confidence, and self-esteem. So it was a really impactful study and led to some fantastic awareness and media coverage and resources that were developed on the back of it. And if you'd like to learn more about this study, we actually covered it in Monday night's webinar with Dr. Hayley Guinea, who's a researcher from Jean Hales, and that webinar has been recorded, and the recording is actually already available on the website. You can just find it linked on the main event page. Next, I'd just like to give a quick thank you to our event sponsors, the Brain Foundation, AbbVie, Pfizer, and Lundbeck. Thank you so much for your support. This event wouldn't be possible without our sponsors, so thank you. Next up, you're in the right place tonight if you or a loved one are living with a migraine or headache disorder. If you want to connect with others like yourself, you can talk in the chat and learn from each other and all the fantastic questions that are asked. And on to the next point, if you'd like to ask a question for our expert, Dr. Bronwyn Jenkins, tonight. I'd also like to mention our Facebook peer support group. I know that Facebook isn't necessarily everyone's favorite platform, but it's a really fantastic community. There's over 7,000 people in it now. And it's a great place to speak to other people and get support, especially if you're not really sure who to speak to in your everyday life about it. It's an amazing place to go and be listened and share your experiences with people. So to introduce our speaker tonight, Dr. Bronwyn Jenkins. Dr. Jenkins is a neurologist from Sydney. Her undergraduate training was at the University of Newcastle, and her work is primarily in private practice with a subspecialist interest in headache, as well as running the headache clinic as an Honorary Medical Officer at Royal North Shore Hospital. She's written a postgraduate course in headache for the University of Sydney with an ongoing interest in headache education. She's an assistant editor for Cephalalgia, and she's active in publications relating to headache. She's the immediate past president for the Australian and New Zealand Headache Society, and she's a member of the Australasian sorry, I have forgotten the Asian Regional Consortium for Headache. Sorry about that, forgetting the acronyms, and the International Headache Society, having been a co-opted member on the International Headache Society board from 2018 to 2020, and continuing on the Education, Leadership, and Ethics subcommittees of the International Headache Society. So thank you so much, Dr. Jenkins, for being our speaker tonight. We're so excited to learn from you. And if you haven't seen me before, my name is Anik Grunty. I've been at the Brain Foundation at Migraine Headache Australia for 5 years now. I am the grants program manager and digital lead, so I manage the administrative side of our research grants program, and I also write a lot of our website articles, newsletters, and host events such as this for Brain Awareness Week and Migraine Headache Awareness Week. And also Carl Cincinnato, who you would be familiar with if you attended any of our other sessions. Carl leads Migraine Headache Australia and has lived with migraine for 35 years. He's dedicated to lifting the global burden of migraine via Migraine Headache Australia, the Brain Foundation, the Coalition of Headache and Migraine Patients, the Global Patient Advocacy Coalition, and the World Health Education Foundation. He's a member of the International Headache Society, and he's also the founder of the Migraine World Summit. He's a public and passionate patient advocate for migraine, and he's spoken nationally and internationally on TV, radio, and in print about migraine and the need to increase research funding, reduce stigma, and increase patient support. So he'll be moderating in the chat tonight, and you can ask him any questions, or if you have any trouble, he'll be happy to help out.
Hi, I'm Bronwyn Jenkins. I work in Sydney as a neurologist with a deep interest in headache. So I hope you find this talk interesting. We love hearing feedback every year. And so this is an amalgamation, a bit of a potpourri of things that people have asked for, which will go over symptoms of migraine that aren't just the headache, trigger management, and headache in the old age group, sticking to migraine. So these are my disclosures, none of which are particularly relevant for this talk. So going straight into how to live well with the symptoms of migraine, because I think we're still trying to debunk people's understanding of migraine being just a headache and everyone understands it. I don't think everyone does. Migraine is quite complex. It's a neuronal sensory processing disorder is the easiest way of looking at the pathophysiology or the cause of migraine. And it's something that's genetically based usually, and it can have acquired triggers. And even if those triggers settle down, the nerves can keep firing off. But the thing that sets it aside from other headache disorders is that you have sensitivity to environmental triggers. So light, noise, everyone listening probably understands this. So when you look at this graph, you've got the controls in the black, and then you've got the tolerability for people with migraine, with or without aura, with and without attacks. And even when they're not in an attack, they're more sensitive in their brains to any stimuli externally. And then I really loved this picture because another way of looking at the function of the brain is on a PET scan. And you've got the controls are on the left. That means people without migraine. And then on the right, you've got people living with migraine. And top is when they've got pain, and bottom is when they're between their attacks of pain. And even when they don't have an attack of pain, you can see that the back of the brain is lighting up to stimuli in the visual cortex, which is where we perceive light sensitivity. So I think that's really interesting to show you that it's not just that you're imagining or wanting to be more aware of the environmental triggers. It really is part and parcel of this disorder. So migraine is so much more than just the headache phase. We've got prodrome, and in fact, a large proportion, well over 50% of people in a survey of a headache clinic could pick that they were going to get a migraine based on their hours of symptoms before. So they could have problems concentrating, speaking or reading, changes in how often they go to the bathroom, fatigue, nausea, and neck tension. And so if you can pick that you've got a migraine, surely there'd be a useful treatment for it, but we don't have any treatment targets for that group. Some people don't diagnose migraine if they don't have aura, as part of migraine, and it is, but it's for the minority. So 3/4 of people won't have aura, and those people that do have aura won't have it every attack. And aura is a really specific stage where it's neurological symptoms, usually before the attack starts, sometimes overlapping, sometimes for longer than it should, but it usually lasts up to an hour. And then, of course, you've got the headache phase, which has more than headache. It has sensitivity to light and noise, and it has some nausea, but it doesn't have to have a full hand. And then the postdrome phase. So it's really validating to know that a lot of people feel washed out. Some people even feel euphoric as they return back to normal. But before that, you can feel quite flat and down. And again, it's not something that you're experiencing alone. It's something that's really common in migraine disorder. So I think rather than harnessing it, it is helpful to know if you have to lean into it or explain it to the people around you, because I think we can all be good advocates for migraine to increase the understanding that it's more than just a headache. The worst bit is sometimes that if you're having frequent attacks, you get an increasing amount of what we call interictal, which means between attacks burden. So we start to be worried about the next attack before it's started. So you're obviously got headache that's not helping you function at the time, but then in between it also starts to be part of your daily living. So that's the 4 phases of migraine headache, and in more recent years we've also recognised that there's a degree of anticipation and worry that goes with frequent attacks. The reverse is, though, with better treatments you do much better. So I think lean into rest if you're worse, but take the opportunity to understand your symptoms and exercise when you're well, because healthy lifestyle is really useful, as you're going to see. I think you've all got the chance to influence future health policies and priorities as to where the community puts its funding. It's a common disorder that's still commonly misunderstood and underestimated. And rather than lying in a dark room vomiting into a bucket, most people are out and about trying to be present. And so this is presenteeism as rather than absenteeism. The migraine disorder is not only when you're lying in a dark room, and some people never have to do that, but if you've got any headache with the associated features that's taking you away from being fully present with your activities or limiting activities, then that's usually migraine disorder if it's a recurrent stereotypic headache disorder. So we've got to tell the people around us who are watching us and thinking that we're just opting out transiently, and the reason I say we is I get occasional migraine myself, what it's like, so that they understand what we need from them, including in the workplace and the community. So moving on to trigger management. So, well, what is a migraine trigger, first of all? Because a migraine trigger is not a cause. And triggers are measurable things that are internal or external, so endogenous or exogenous to the body, that increase the probability of headache over a specific period of time afterwards. And there's very big individual variation in the relevance of trigger factors. So I think amongst ourselves we can't all compare exactly what is factual based on what someone else has learnt for them. So we've got the top 10 migraine triggers from a whole range of surveys and migraine buddy diaries. So stress is the leading. And I think that stress is the most palatable term in Australia. But in fact, sometimes if there's normal daily stress or normal life stressors, because there is a circle of life and there are a lot of financial things and other things going on in the world, we all have some external stress, but it's how we carry it and how it triggers us. Sleep is a really strong trigger. So I often look for these 2 things, particularly if someone's having a worse variability of their migraine attack despite being a previous responder to their treatments. And then you've got the other things: bright lights, noise, weather changes, skip meals, dehydration, and some foods or strong odours. So sometimes when I'm trying to figure out whether someone has migraine, I ask whether they're triggered by things like smells. So some of these triggers, though, in the shift in our thinking, is that some of them might actually be premonitory symptoms. So that comes from similar imaging where you can see areas of the brain lighting up well before that headache phase. So it was good that we went over that curve before, because you can see that there's these pre-actual before the episode starts lighting up of the brain that's causing the neurological symptoms that are the typical premonitory symptoms. So if you get neck stiffness before your headache, it does not mean that the neck caused the headache, essentially. So I think that's helpful for people to understand why sometimes the things that only accompany the headache are still considered part of the migraine disorder, as opposed to if you have neck pain on every day of the month, then you have an independent neck problem with migraine sometimes triggered by it. So it can be either or, premonitory or trigger. So then we've got useful information resources. So I think it's very frustrating when I first meet someone for that person that I'm looking for all the trouble. It sounds like I'm critical, that they're not sleeping right, that it's their fault somehow. It really, really isn't. But if we can identify any lifestyle issues that are triggering the headaches more than need be, firstly, that leads to better real-world outcomes, but it's an opportunity to treat those things. So if we can recognise that anxiety is triggering from normal daily stress, we can manage that. As far as lifestyle triggers, there's self-care handouts, and we've got one in Australia and New Zealand with the Headache Society website that you can easily download to have a look at what the experts have agreed on as useful information. I like this quote, "The problems are only opportunities in work clothes." So going on to the environmental triggers. So because it's part of the disorder to have sensitivity to light and noise for most people, it's obvious that if you have bright lights or glare or even screens, that they can trigger headaches. And again, it's not a new thing that it's been thought about as to how to minimise glare in the workplace with anti-glare screens, decreasing flicker rate, changing where you sit at work. The working from home stage post-COVID's been useful, and some people also get anti-glare styles of glasses. With smells, you could ask workmates to not wear that perfume or to not use that cleaning product. And so these are all normal physiological triggers for migraine. Also not skipping meals, not being terribly dehydrated. For athletes, it's useful to rehydrate with fluids that are absorbed really quickly. So if you have a certain amount of sugar and a certain amount of salt, which is in the hydration fluids, then you actively pump it across the stomach cells and you can rehydrate much quicker around the time of the strenuous exercise, particularly in the hot summer of Australia. So recognising these can help the person. Less so do we find a single food. So obviously if there's celiac disease or something that with absolute intolerance, there needs to be a complete exclusion of that food. More often we're looking for cause, and we find that we get it more often on the days we eat sugary foods or whatnot, without it being the controllable factor that makes the migraine day reduction go down massively. So think about food groups, but rather than like an allergic rash, you can't exclude it, then reintroduce it, and then expect the reaction the next time you use it. So I often advise, and this is not scientifically robustly studied, or even how the books frame it, but I often, from my clinical experience with patients, suggest you exclude a single food at a time and then go back to trying that food again when you're reintroducing it multiple times to see if that's a factor when you stress, when you've got your hormonal periods, all those other things, because it's usually a combination of factors when it's a food that's partially triggering things. Mind you, some people will always exclude red wine and other alcohols, so there are some that are stronger than others. And then leading on to this concept of stress being the leading trigger. Well, we do know that anxiety and depression are really comorbid, which means, in fancy doctor talk, it's more increased in frequency with migraine disorder. So you can see this graph here where you have the people with migraine having higher rates of depression and anxiety. So if there's a complex and bidirectional relationship with these two things, then it's really useful to have strategies to manage them. And rather than crisis management, which is how I look at mood disorder management, in migraine, it's not even wobbling. So I find it very useful to have a daily practice, and that can be different for every person. Some people pray, some people knit. Most people will choose a guided practice, often app like Headspace or similar, where they can learn how to do deep breathing, relaxation, mindfulness, whatever is the thing that you like doing for that brief period of time, like about 20 minutes a day, that then you get so good at, you carry it away with you. You can be in the back of a taxi doing this breathing technique, you can be in a busy work meeting without people recognizing that you're now controlling your mind rather than your mind triggering off migraine from stress. So Dan Millman said you don't have to control your thoughts, you just have to stop letting them control you. So it's not just anxiety or stress that leads to migraine, but it's certainly a really powerful tool when we're using our best treatments to also help with. So just to put that into frame, when your doctor starts talking about stress management, it's 2 to 10 times more prevalent to have mood and anxiety disorders with migraine than the general population, and it's really common to have post-traumatic stress disorder and really useful to look at that. 25% of people with migraine meet the criteria for mood or anxiety diagnoses, and we think that's because of the overlapping neural pathways. So there's the serotonergic and dopaminergic dysfunction of migraine that parallels actions in the mood disorders. There's also environmental and genetic factors. It's pretty hard to be happy when you've got frequent migraine, but there's similar parts of the brain as well. So based on that pathophysiology I showed you earlier, there's overlapping reasons why you'd expect these to be hand in hand in some people. So obviously, psychology, access to deep and intensive treatment is very useful, and even medications on some people, but a starting point is to do a daily practice. So it's really useful to have any of these apps. A lot of the apps overseas we don't get here, but we do have a biofeedback one even, but often Headspace, Calm, Curable, whatever is your most accessible and pleasant way of controlling the mind for 20 minutes a day. So there's been a lot of studies. We're actually getting Rebecca Wells out next to Australia next year because she's such a guru in this area, and she has done a lot of studies in mindfulness-based cognitive behavioural therapy. There's stress reduction techniques as well, and like I mentioned before, biofeedback. So for more involved strategies, these are very evidence-based in reducing migraine frequency. And then, of course, there's medications. So in general, SSRIs would be not the first line because they can, in the minority, increase migraine. So if you can get the same improvement in the mood with an SNRI or other class, then that's usually helpful. On to sleep. So remember, that was the second one down. So sleep is really comorbid, and I'm often looking for a sleep disorder, and I ask people whether they sleep well, and that's sleep, not just the hours in bed, and whether they wake up refreshed, how they wake up, like do they wake up to an alarm, and also whether there's signs like heavy snoring or family history or seeming to stop breathing overnight based on their bed partner. And then there's really useful things you can do. You can help them with sleep hygiene if not getting to sleep okay, use even digital cognitive behavioural therapy, and there's a whole lot of resources that's designed for doctors, but when you look at it, it's quite easy to digest at this Sleep Primary Carer Resources page, and I checked that it's accessible to people without an APRA number, so you might want to have a look at that. Okay, so that was 2 bits of it. Now onto migraine disorder in the older person. Because there's nice narratives about how, despite having an increased prevalence in young people, particularly around their hormonal years, it should get better by the female stage of late menopause. And that's all very lovely for the people that happens in. But there are people, obviously, who still have their migraine attacks well into older life. So we've got the prevalence here in this graph of what age you'd see people at. So you can see that peak in younger life, but you can see that of the group that hold on to their migraine disorder after the age of their mid-40s, they often continue to have be a significant group with migraine disorder. However, that group should have had some migraine attacks, even if it was to alcohol, smells, other triggers. They should have some migraine attacks before the age of 40 and definitely before the age of 50 for it to be diagnosed as a primary headache disorder. Otherwise, we'd be really considering there might be an underlying new secondary cause. For a lot of my patients that continue to have their headaches is because there are acquired factors sustaining it, but there hasn't been really good studies of this. So it's all very nice for us to know what the majority is, but if you're in the minority, then we need to know more about how to manage this. So older patients are often excluded from clinical trials, which interferes with our ability to extrapolate what's been done for a group group where the median age is 42 years of age. If you're 75, that's quite a different age group and quite a different physiology potentially. So why are they excluded? Well, it's because there is confounding other factors that interferes with studying a single disorder. So they're often excluded by pain syndromes, other medical conditions and intolerances, as well as polypharmacy, so multiple medications that interfere with knowing that we're really testing the safety of that one medication. So it means that we've got to be cautious about making too many conclusions in the early years of new treatments about the safety and effectiveness until we have some real-world data. So that stands for anyone over 65, but particularly the over 80 group are less well studied. So I think in the older age group, we would often look to make sure that there are no other illnesses that need to be managed. And this goes back to the red flag mnemonic of SNOOP4, to look for whether there's an underlying condition, inflammatory, neck or otherwise, that is driving the headaches, whether there's atypical features, making them more severe than expected, or a different shift or change, like a more progressive, continuous, nihilistic headache, or any pressure features. It's only when someone coughs or strains that they get their headache. And they would concern us particularly in the older group. But even without those other features of the red flags, the first headache being more than the age of 50 would be concerning and would prompt further investigation. So this group, even if they don't have localizing features, would often be the ones to do some investigations on. Firstly, we'd do some blood tests, and then secondly, we'd examine them carefully, and certainly you'd always check the blood pressure. These are some pictures to show you that the other sorts of conditions. So basically anything in the head and neck above C4, so it's a higher neck, can trigger more headaches. So here's a neck that's not looking too aligned. Obviously, if you've got lots of things in your sinuses, so sinusitis, that can be a trigger. And then if you've got something else happening in the brain, so we've got an inflammatory process of lupus and we've got an intracerebral bleed from a clot during the COVID era. So anything that is making that person unwell can increase their underlying migraine disorder. So we often reinvestigate if there's a marked shift and change in someone's headaches. And every person I see will get asked about these things: hypertension, neck issues and injuries, grinding their teeth, sleep disorders, caffeine, and we usually only allow 1 to 2 shots a day, mood disorders, medication overuse, which means more than 15 days of simple painkillers or 10 days of stronger things like the triptans, sinus disease and other illnesses, because they're all highly relevant to that person's health. So the medication considerations in older patients are also more complex. So we have to take into account any other issues. So if they've got high blood pressure, well, it's great to use an antihypertensive. But if you've got a slow heart rate, don't use something that slows the heart rate, for instance. So the classic is if you've got a beta blocker, that's first line in some young people based on GP practice, you wouldn't use it in someone who's got chronic airways limitation after some earlier life smoking, some congestive heart failure, diabetes, so they need to know about their hyperglycemic episodes, glaucoma, or feeling flat already from depression. So you really have to be careful to not make that person's other conditions feel worse when choosing the medication. And we also, when choosing medications for those other conditions, make sure that we're not choosing medications that can trigger off worse headache, as well as looking very carefully at the list of medications they're on to make sure there's no drug-to-drug interactions or even drug-to-food interactions in that group. Fortunately, we've got the over 65-year age group included in our recent practice recommendations. So they had an acute and a preventive paper that you can see here on this slide. And basically they want you to use simple things like paracetamol with caffeine, as a second line, acetyl salicylic acid, which is essentially aspirin here, and non-steroidal anti-inflammatory medications as long as it's tolerated by the gut. And we would be cautious in the setting of cardiovascular or cerebrovascular disease that's active, so that's heart attacks or strokes or angina. But otherwise, we'd still use the triptans in the older group because they've been around for 35 years. So then we'd use nausea treatments just like we would in anyone else, but probably not the ones that will lead to sort of Parkinson's type symptoms in frequent use. And then as far as migraine preventives go, there's still interest in monitoring some of the new drugs, but they have been studied already in the up to 80-year-old group without safety issues, so they're still an option. And I find that this group often, if they've got frequent headaches, will benefit from Botox, which can be a really safe treatment if it's handled correctly to avoid any muscle weakness. So I think migraine can persist with older age, but there are still treatments as long as you just stop and pause and consider it in the setting of that individual person. And that's why headache management is so rewarding, because you can do better if you treat the person as a whole person at any age. So a bit of a potpourri, 3 things to cover. So migraine is much more than just a headache. And I think understanding the different associated features, but also the premonitory and postdromal phases, as well as the worry between attacks, can really help that person to understand what to expect, what to treat and how to treat it, as well as getting people to understand better in work and wider community settings. Managing triggers is really individual, but some of them might actually not be a trigger or a cause and might be actually part of the premonitory phase that's inevitable once the headache's already kicking off. And then we have to wait and treat the headache phase. They're very variable, so try not to compare with your best friend as to what's the most important thing, but it helps to understand what's important as a group and to know that for every problem you find there's a potential solution. And then to not feel alone if you still have migraine in older age, and to know that the usual principles are similar as long as they're done safely in the setting of that person's other health issues and other needs. So it's fantastic to get the opportunity to talk to you, because Headache Week is so important for increasing awareness. So I hope you go forth and take that information with some utility and can educate the people around you about your migraine disorder. Thanks for listening.
Thank you so much for such a fantastic presentation, Dr. Jenkins. That was really interesting, and so much great advice was shared. So thank you so much, and we're really excited to get into the Q&A.
Thanks, Anik.
Yeah. So the first question that we have is from an anonymous attendee, and they have asked about the new, this is a bit of a left of center one, but the new bright lights that are in newer cars, like the LED headlights, and they're saying that it's difficult to drive due to the light being a trigger. And we were wondering if there was anything, that you have heard from patients or anything that helps them manage that.
Yeah, so I think bright lights at night as a whole is more of a trigger than because it's the contrast. And people have different reasons for being sensitive to light. Some people will have other brain disorders, such as high-functioning autism, where they get abnormalities looking at a white wall or any checkered pattern. So there's reasons people have these different thresholds. As a whole, most people with migraine disorder will be able to go out at night, will be able to drive a car, will be able to even, be on the freeway with someone coming down with the high beams. But if the person is that sensitive at that stage, there can be 2 things. One is obviously the eyes. So a lot of my patients actually, it's interesting that we're talking about the older age group, and I feel nervous calling anyone old these days, but talking about that age group, there's often an eye issue as well. So this is the thing about triggers. It's often multifactorial. And so if your eyes have had cataract surgery or have a cataract waiting for surgery as just one of the many things that can go wrong with eyes, then that will also reflect the light more, and that could be a stronger trigger for you at that age and stage than it could be for smells at that age and stage. But at the same time, I've got young people who find that night driving is just that's their threshold. They just can't do that. So I think obviously having the lights we have in our own environment, we have some control over. We can have the screens, we have altered flicker settings for our computers, we can position our desk so we're not looking directly into glare. We've got some controls over some things, but other people's headlights coming at us is very confronting when that's the trigger. As far as the new cars being worse, I haven't heard that yet. So I'm hoping that isn't, because otherwise I don't like it when everyone becomes sad and things get worse rather than better, because I think at the moment we're in a stage where the glasses, the awareness of doctors about these being real phenomena and also the ways we can help it are improving. So, within Headache Australia, you've got a wealth of experience about different glasses that people have found useful for their different eyes. Fortunately, there's some costs involved with each one, and so you don't want to mortgage the house or become without a home just trying to get all the newest whiz-bang things if most of them aren't helping. But certainly there's things that I think this group can, like they're sharing information, lean into and try, if they're an affordable option for that sort of thing to allow driving at night. But I don't think the new ones are brighter. I think there's a bigger problem with them that we will talk about in a different session that's a bit more political.
Yeah. No, of course. Great. Thank you so much. Some great strategies and ideas there about managing that. The next question is from Jodie Ann, and she is asking about perimenopause and why it causes so much trouble with migraine.
Yeah, so perimenopause is a party for the body, but not us. Everyone thinks it's just a decline in hormones, and remembering that the hormonal factors haven't been more studied. So it is now being much better studied internationally, which is great. But we've got these very simplified pictures of what happens. We blossom into menarche and then we have this sudden drop off, and it really isn't like that. So just as the ovarian function is dropping off, we're often having bursts sporadically, unpredictably. So the group that go through life, that graph where things come out at the hormonal age, that group that are worse with hormonal change, it can be a small shift of estrogen that's not even big enough to trigger any withdrawal bleeding. That group suddenly are prone to having a worse headache or more frequent headaches when they've got any fluctuations. So that can be it went high and then low, or it can be it's dropping off like the common scenario is. And so it's just all over the place, basically. So rather than being cyclically once a month that it's a disaster, I shouldn't use hyperbole like that, but when it's really, they are the worst type of migraine attacks for a lot of people. Those can occur unpredictably, which gives that person more of the worst hormonally related attacks. And the difficulty with that is that fluctuation starts well before hot flushes and other things that are more tangible and easier to measure, just like migraine studies being so caught up in headache, because it's easier to measure, it's easier to ask study groups, it's easier to grade out of 10. And so all of our hormonal stuff looks at menopause rather than the perimenopause, the years before. And so Anne McGregor, who I take most of my cues from in this area, and she's in the UK, she thinks it goes for about 5 years. And I remember cheering when I heard that, because I also think it goes for about 5 years, sometimes 10 years, that things are a bit in flux. And so it can start well before the person's menopausal, well before they need HRT for all the other things that are causing sleeplessness or shift in their physiology. So it's a really difficult phase to treat, but it's a bit of a party all over the place.
Yeah. Well, hopefully we can see some more research going into that area and get some solid answers in the future. The next question is about the postdrome and prodrome, and asking whether we can do anything to reduce the impacts of those phases, because some people find that it wipes them out more than the attack itself. So any strategies on that side?
Yeah, I really appreciate that question. Sadly, we don't have acute therapies for that group. So we use, just like with aura, which is similar, all the acute treatments have been made for the acute headache phase. So if someone's really severely affected by that, I would use migraine preventives. If the migraine preventive is something you take regularly to decrease the frequency and severity, if that reduces the headache phase a lot, then it should also decrease the other features of migraine. If it doesn't, so for instance, if someone has daily vertigo when they're having their chronic migraine and a CGRP monoclonal antibody therapy, for instance, suddenly decreases their migraine to almost nothing, then it puts into question that there's other future driving forces behind the vertigo still staying behind when the migraine's been sorted out. There hasn't been specific studies on how well it can treat the premonitory and postdromal phase, but from my clinical experience, that most patients will find all of their migraine symptoms better, including the biggest attacks. So, decreasing the frequency and severity overall is what we try and do. And then if there's other things like brain fog every day pervasively, chronic fatigue every day pervasively, or a sense of imbalance like on getting off a rocking boat every day, that's less, rather than being episodic, like migraine comes and it goes and the phases come and go in that little graph, then we'd start thinking about, well, are we missing an inflammatory disorder or something else going on in the body that's causing that, rather than it all being the one cause of migraine disorder that's been sorted out. Because the things we have now are really migraine specific. So they're really good at stopping a headache being a migraine and all the things that come with a migraine. And it's really those bothersome symptoms, the other symptoms of migraine, that really do limit people so much, rather than tension type headache being not a problem for most people.
Yeah, I guess that does make sense with all of the comorbidities and everything, how you were talking about, possibly looking at other conditions there if it does persist with preventive treatment. But yeah, hopefully most people find that preventive help. The next question is from Donna, and she's asked when chronic migraine is present every day, even when using a preventive like a CGRP, could it cause other chronic inflammatory conditions like what you were just talking about? She's mentioned cognitive dysfunction or myalgic encephalitis.
No. So I think that's the thing. Migraine disorder is migraine disorder. And I think despite everyone's varied experience, we've got enough under that umbrella. There's a lot of anything else that makes you sick, though, will worsen your migraine disorder. So often migraine goes hand in hand with other overriding conditions. I've got patients with everything, and so they'll have an inflammatory disorder like systemic lupus, including spots on their scan like I showed. And that person really needs treatment for their underlying condition. They really need to sort out why they've got chronic fatigue, or if they're having their memory going off, why their memory is going off. There haven't been dedicated studies, to my knowledge, about cognitive decline. But the good news so far is, even though people with migraine often have more little white dots on their MRI scan of the brain, which I'm sure I do too, it doesn't have a clinical correlate, which is, again, fancy talk for saying it doesn't seem to relate to later problems with memory. And I've had a deep passion for headache for at least 20 years. And I've seen a lot of perimenopausal women now become women in their 60s and 70s. And I'm sort of going, where are they? As far as, the next neurological problem they get will be a memory problem. I'm not seeing the group that were in their 40s now coming in 20 years later with cognitive decline ahead of the other group, whereas I do get people with cognitive decline coming in as well. So we're very interested in the vascular effects and the brain aging effects of anything, including normal life, but particularly in the migraine disorder group. So we talked about that at our recent headache conference, and the international guys are also interested. But the good news so far is we don't think that the more attacks you have, the more you decline chronically after your migraine attacks have been managed. It's literally that migraine is so debilitating when you've got it, that we should be reducing the frequency and severity. And we shouldn't stop when it's 50% better. We're involved in a recent statement with the international group saying we don't want people to be half better. The group that are now 80 or 90% better, they're truly living life. They're able to drive without worrying about headlights, right? So we want everyone to be 90% better. We want attack freedom. We want to be like the epilepsy group, where we don't accept that you have a seizure just when you get your driver's license back here and there, or you have a migraine every time you were just about to get a promotion at work. We want better outcomes for migraine. So I think we need better preventives, but if it's not tying in with your episodic increasing in frequency or decreasing in frequency with treatment improvements, if it's not fluctuating like migraine disorder associated with migraine features that are enough to qualify, because you don't have to have all factors, then you've got to really think with your GP and other specialists about whether there's another condition as well.
Yeah, no, that's a great point. Thank you. The next two questions actually kind of go together. And Nicola, from Nicola and Leanne. So one question is about the stages and cycles of migraine, and how does that work in something like status migrainosus, where it's continuous? Is that an extension of that peak migraine phase? And the other question that kind of relates to that is that about vestibular symptoms persisting between migraine episodes. And so I guess that continuation of attack again there. Yeah, can you talk a bit about that and how that relates?
So I think I'm seeing a lot of patients with a better disease-specific preventives as well as acute therapies that have these grumbling, persistent symptoms. So I'm going to go to the second question first. So with the vertigo one, if the migraine disorder been sorted out and the triptan use massively decreased and the headache's better, the sensitivity to light and noise, nausea, preference or need to rest, if all of these things are improved, but the person still had a daily vertigo, then I think the vertigo is something else. I'd be doing hearing and balance tests. Do they have Meniere's? Do they have a family history? Or is there a perceptual dizziness, which is really common and it's hard to stay away from if you've actually had such chronic ill health threatening your life and lifestyle that you have been looking out for all external environmental triggers. So that needs really complex psychological strategies, and it can be really helpful to get the person on the right track for that rather than still keeping it under the umbrella of behaving typically like migraine when all other migraine symptoms have improved more than 50%. So that's the vertigo side of things. The status migrainosus one is really interesting. To be a little controversial, I don't work in an acute hospital, so I don't see that group of patients. But usually when someone tells me they've got status migrainosus, I go, well, why? What's wrong? What in the upper head and neck, and what in life, like having a new COVID infection or a massive bereavement or something, is going on to make that headache last more than the natural history of 3 days of a typical migraine attack. So sometimes there's hormonal factors to that too. You've got to look for the offending supplement, medication, whatever has just been changed within the last months to gradually get them worse into a totally vicious loop. So status migrainosus is not something that I diagnose often, because more often I see someone who's having migraines that used to be 4 hours to 3 days, and now they get 10 days to 2 weeks in a row. And in that person, I can invariably find musculoskeletal tension causing their side-locked headache. That is because they've got an ongoing sustaining trigger that's coming at them every time they're holding their head up on their toothpick by the end of the day or lying in a sustained position on their pillow overnight. So I look very carefully for why they have long attacks. They've been born with the ability to have migraine disorder coming out at the typical age. Doesn't come out at birth. And if it comes out more at a greater frequency, you think, well, why? And you look for an underlying cause. Even though most people come to me looking for a cause and I say, you won't find a cause, it's a polygenetically based thing that your head is like this and, we've all got something. So, so hopefully the status migrainosus, as far as the stages, hasn't been looked at, because I think it's a totally different group, and I think it's probably it's an easy term for people to say, but rather than when someone comes back and say my treatment's not working like usual, I've had a really bad 2 months, I go, why? Who died? How many hours of sleep are you getting? How much caffeine have you snuck up onto and having withdrawal overnight? How's your neck? Show me your rotation, even if it's by telehealth. So I really, really don't stop until I find something that's manageable, and with that I get pretty good results clinically, but it's not something I could put in a paper. And my most disappointing thing I was involved with was a paper where we were trying to help people with migraine after the age of 65 in older age, and we just weren't allowed to say half of the things that we find clinically relevant because they weren't proven in papers. So you've got to take everything I say with a grain of salt. I'm just one human who's interested in headache, but that's been my experience, that status migrainosus is, rather than just going, oh, it's status migrainosus, quick, you hang up the magnesium, give them an infusion. It's sort of like, well, why have they gone into a vicious cycle now, having had years and years of typical migraine? What's making it keep coming back? And, most classic example is those online who have had or have menstrually related migraine will know that those attacks can last for 4 or 5 days because there's a sustaining, ongoing daily drop of estrogen. And so it can be a longer attack when something else is going on in the background.
Yeah, thank you for that answer. That was great. The next question is about migraine and IBS. Is there any link that's been found between migraine and IBS?
Yeah, absolutely. So there's 2 IBSs. The one's inflammatory bowel syndrome, which is Crohn's and ulcerative colitis, but most people are talking about irritable bowel syndrome. And so migraine has a lot of autonomic features. So we've got our central and our peripheral nervous system, and then we've got our autonomic nervous system, which is really sort of handy because it empties our stomach and it runs our heartbeat, and it's involved in all these things we take for granted. And the group with migraine have a lot of associations. So we have a lot of postural orthostatic tachycardia, where the baroreceptor or for heart rate just isn't working, and so you stand up, your heart goes crazy and goes really fast. Or we have the other group where their blood pressure drops down. And similarly, we've got a lot of gastric emptying problems, and we've got many, many, many more patients that have irritable bowel syndromes. So we complicate that by using medications that are constipating, whether that's codeine, which we don't use very often, or even ondansetron, which is an anti-nausea tablet, and the CGRP treatments. So we can feed into that. And then there's, of course, natural things like magnesium can cause diarrhea in someone who's prone to that side of things, and it can be quite welcomed in the older age group or the group that have more constipating symptoms or have just started their CGRP treatment, because it will actually balance out that it's not a constipating thing. So the irritable bowel is often linked polygenetically, we think, but no great linkage studies. But it can be made worse by the medication, and certainly it goes off before in the premonitory phase and during the attack. There's definitely differences in someone's bowel function, and so it's not surprising that a lot of my patients have gut symptoms as well with their migraine attacks. Can I just point out in the question, someone said describe their Avalux as a warm hug to their eyes. I thought that was beautiful. There's a lot of people talking about their glasses, and I think that's really useful for people to share information online like this.
No, it's a fantastic forum every year, and it's always great to hear about people's experiences with all these different things. The next question is from Carmel, and they're asking if Botox works better when you're on Emgality, or I guess just any CGRP medication. How's the interaction between those?
Yeah, so Botox itself has no interactions with other medications other than neuromuscular blockade. Very exciting. Someone came in, they're about to have an anesthetic that afternoon, thought it would never happen. I said, you can't do that, and we'll give you Botox on Monday. So that's it's interaction neutral. CGRP monoclonal antibodies are like a key and lock situation, and I'd encourage anyone who missed, I think it was Emma Foster did a talk earlier in the week, to look at the talk about therapies. I'm so sorry. So that means that they won't interact with anything other than CGRP. So they don't interact even with other monoclonal antibodies. So they're really compatible together. They both have rates of reduction of migraine frequency and severity to the responders and not to the non-responders. And we have real-world data, and same with my clinical experience, that they are adjunctive. So they work, they help someone who's partially responsive to one and partially responsive to the other, but not yet good enough. If they're accessible, they can make a better response. But because of cost effectiveness and the limits of our PBS, because it's all taxpayer funded, you can't be on both on PBS. So you have to do a private pay for one, to have access to the other. So whilst we know that they can work better, just like an oral medication, or some of my patients are on several, as long as they're compatible and there's more interactions with the orals, it can be good to be on a combination, but I don't think they make each other work in a synergistic way. So it's not like the CGRP is acting on the Botox receptors, but they're definitely being half better and then being another half better is, 75% better in that person.
Yeah, that makes sense. That's great. Thank you. The next question is from Jessica, and she's asked, how can you kind of tell when a scent is a trigger, and what does it feel like when it's bothering you? And some people have kind of shared some comments there on that question, which are quite interesting about those sensations when you're starting to experience a trigger. Is there any, I guess, like actual data or research about that?
I don't think there's good data. So even the MRI studies we're doing, they're functional MRI, and so it's very difficult technology, and so it's individual scans. So everyone's experience is different. That's why I was saying don't always compare with your best friend. But I did love that, just the descriptions that were coming across. And I was talking just today to a patient about how I know if my migraine's an MSG, triggered migraine. I won't go back to that restaurant. I'll go to the other Thai place. So whilst that's useful, I think at the same time they're all migraine attacks, and also a trigger will usually take some time to trigger it. The reason people are so aware of it immediately is because their head's already sensitized. They're already in that premonitory phase. They're already getting their migraine attack. So if I'm giving someone needles on the day they're having their migraine attack, they are really sensitive to their needles. And that's not because my needles are worse and it's a worse trigger to them. They're already in the attack. It's just they haven't got to the headache phase yet. So be cautious about what we call an immediate trigger. And I think glare is often not so immediate, even though we're always, even between attacks on that imaging, more aware of sensitivity to light than other human brains. So it definitely goes up during an attack. So I think the ones that are instantly triggered, that's quicker than we would expect to be triggered, the migraine attack, because it takes some time to go from the hypothalamus through the brain up to the headache phase.
Yeah. No, that's great. Thank you. The next question from Leah, she's talked a bit about her experience with migraine over many years, and she's said that she previously used to take medication and rest, but now she's kind of more just working through it and taking the medication, but continuing to work. And I guess in general for everyone, could the lack of, and now her migraines, sorry, I forgot to add, her migraines now last up to 2 weeks when it just used to be a few days. And so could that combination of that lack of rest be contributing to the prolonged attacks? Is that something that's seen in people?
It's a bit double-edged because a lot of people that rest get worse orthostatic tolerance, which means that their blood pressure doesn't adapt as well to getting up. So we encourage people to not always rest, which is a little counterintuitive, but certainly stress will increase things, and tension. So often, if you're hunched over a computer and stressed and not able to stop, not able to access your medications early, not stopping the migraine within an hour rather than letting it go for 3 days. Yeah, it's a vicious cycle. But like I've alluded to before, a migraine should only last 3 days. So I suspect there's sustaining factors there. So I don't think in the trigger management discussion that we are causing future decline. I think it's useful to know some of the things, and like all things in life, you do what you can. You don't, and you must never, ever, ever feel that it's because you're doing the wrong thing. So I think having leave from that situation to see whether that reversed it for that individual in their individual case, because it is so beautifully variable and individual, and that's why it's so fascinating. That would be really useful for her, but it might not be useful for another person. But don't quit your job, and go, right, that's it, I can't function the rest of the time, I must go on to disability. Because I think, also online there are people saying, I've had migraine since the age of 11 and I'm not disabled, and that's also brilliant. So find the solutions for you that work within the limits of life, and combine that with really amazing treatments that are so migraine specific that then you know what else you've got left. But yeah, don't beat yourself up that it's because of one single thing, because it usually isn't. It's usually multifactorial. The people that get shifts with their weather, it's usually only when they're stressed and 3 days before their period, so it's not always single factor things that we can control. And sometimes, as you can hear in the things I'm, quoting, they're not things you can control. Normal life is normal life, and you have to get out of bed and do things. So that just means there's way too many migraines, deserves better treatment. And then depending on where you live and who you've been referred to, I think that treatment's available. So I go blue in the face educating people so that all neurologists, all GPs are hopefully aware of the great advances we've made in the last years, and the fact that we're one of the lucky countries that actually has access to these great treatments, as if they're qualifying and able to take them safely, which they mostly are. So it's a good time to get out there and talk to your doctor, and get onto better treatment if the headaches have ticked up and really causing you loss of time from activities.
Yeah. No, it's a great point, and a great note to end on, I guess. I notice we've just ticked over past 8:30. So thank you so much for your time tonight, Dr. Jenkins. It was such a fantastic presentation and Q&A session. Thank you everyone for being here tonight, and all your fantastic questions and comments throughout the presentation. We have one more session tomorrow morning, which is the event highlights and Q&A session with myself and Carl. And so we hope to see you there tomorrow. For now, enjoy the rest of your night. Goodbye.
Thanks for everyone's time. Bye.